Hello, my name is Dr. Donald Jenkins. I'm a professor of surgery at UT Health in San Antonio. I'd like to thank the American College of Surgeons for the opportunity to share our experiences here in San Antonio with a pre-hospital whole blood program and to the conveners for the invitation. Initiating a whole blood program in a pre-hospital setting is not without controversy, and hopefully this will help to answer questions that people have about why one would do it and logistically how one would do it. While I have nothing to disclose, I do have to acknowledge all of my partners here in South Texas, from the Mayo Clinic in Rochester, Minnesota, to the Thor group, the United States Army Institute of Surgical Research, South Texas Blood and Tissue, my partners here at UT Health in San Antonio, and most especially the Brothers in Arms donors. Here in San Antonio, the group convened and discussed use of the National Trauma Data Bank to look at hemorrhage of the torso that you cannot place a tourniquet on. And over this 3-year NTDB study timeframe, 2.5 million patients were entered into that system. The group exclusively looked at those with severe torso injury without severe brain injury, focusing on pre-hospital time and mortality. As you can see, the median hospital time from injury to arrival was 37 minutes in the United States over this time frame. Over 40,000 patients were included in this evaluation. Most of those who died of their injuries died within 30 minutes of injury, meaning that without a change in pre-hospital resuscitation paradigms, we would continue to have potentially preventable deaths on the streets of America. The Thor group has gotten together. This was published in Transfusion in 2016, outlining the logistical, economic, and clinical benefits of cold stored low antibody titer whole blood. Stored out to 21 days, which has adequate platelet function during that duration and is functionally better than one-to-one-to-one component therapy. Further, that group published this in Shock in 2014, stating that low titer group O whole blood is the preferred alternative for emergency transfusion, specifically in injury patterns. Our colleagues in Pittsburgh clearly showed us that there was significant improvement in lactate clearance and resolution of lactic acidosis when using whole blood as compared to component therapy for the injured patients. This map represents our Southwest Texas Regional Advisory Council area of operation. It encompasses 22 counties, over 26,000 square miles, which is bigger than 10 other U.S. states. You can see that there are several counties that do not have resources in terms of helicopters or hospitals, and that the majority of the population lives within Bexar County here where San Antonio is located. This is how San Antonio Fire and EMS divides up the geography of the city. They have 8 medical officer rigs that roam the streets 24/7, 365. These are senior medical officers who have a lot of experience as paramedics in the field. They will go to the scene when EMS needs additional assistance. It could be multiple casualties, it could be shootings, it could be prolonged extrication, patients in shock. But these 8 rigs are the ones that carry the whole blood in a cooler and get it to our pre-hospital patients when they need it. When they need it was a great question, and we used a historical group to show that when the pulse pressure is less than 45 and the shock index is greater than 1, that's the patient population at greatest risk of need for massive transfusion, and we use this as a very conservative trigger. In addition, we adopted these parameters and combined them with 25 years of experience coming out of Mayo Clinic and their pre-hospital transfusion program. And these are the parameters we use by which patients are found eligible to receive pre-hospital transfusion. This is not limited to just trauma. These are the trauma transfusion criteria. There are additional criteria for other patients. Suffice to say, shock being the primary parameter by which one would administer pre-hospital whole blood transfusion. We kicked off this program at the end of January in 2018. We used those criteria as we discussed. We did not exclude women of childbearing potential. And children under the age of 5 were initially excluded. At the hospital today, following Pittsburgh's lead, we are transfusing children down to the age of 2 with whole blood if they present in shock. This is what our whole blood consortium looks like in South Texas. All of the participating agencies, from the military to the hospital, and most importantly, our EMS agencies and South Texas Blood and Tissue. Our whole blood program uses a 1 to 256 antibody titer with O positive whole blood coming from male donors, cold stored out to 35 days with a waste of less than 1%. We have today 13 helicopters carrying whole blood from east to west and north to south across our entire trauma region. There are at least 17 other emergency medical services, mostly in rural settings, that carry whole blood. We get about 20 units of whole blood donated per day. As of January of 2020, nearly 5,000 donors. That was nearly 8,000 donors by this time last year. In the last 9 months, another 3,000 new donors have been identified, coming in at about 300 new donors per month. We routinely have 125 units of low titer O positive whole blood on hand in our system every day. And it is noteworthy that during the pandemic, that low titer O positive whole blood was used in lieu of components when we were severely short on platelets and the patient needed a 1-to-1 resuscitation for purposes other than injury. Randy Schaefer from Southwest Texas Regional Advisory Council and colleagues put together this publication in Military Medicine, and it discusses the operationalizing a low titer O positive whole blood program within a regional trauma system, the how to do it, so to speak, and I would direct you to that manuscript for further details. At least twice daily, we update using a smartphone-based application, the complete inventory. This is a schematic of that. Every aircraft, every EMS rig, every hospital that has whole blood, its inventory, the expiration dates, And on hand on this day, about 2 weeks before this presentation will run, there were 236 units of O positive whole blood on hand in our system. That gives us a green inventory greater than a 3-day supply. And on the left, you can see the number of donors scheduled over the next 3 days that will appear in South Texas Blood and Tissue Centers to donate O positive whole blood. At our hospital, this is the current inventory of whole blood as of this day, 35 units on hand. We have no limitation in how many units any individual can get. We also have no limitation outside of the age of 2 or older as to who can receive low titer O positive whole blood. In fact, we have a collection of more than 100 non-injured patients receiving whole blood, the majority of which, as you might imagine, are GI bleeds, but there are a fair number of peripartum hemorrhage patients and other postoperative hemorrhage patients, to include a couple of patients with dialysis shunt rupture. This presentation is in press currently and will be available for review in manuscript form within the next several months. With that, again, I would like to thank the American College of Surgeons and the conveners of this panel, and I look forward to answering questions during the discussion session. Thank you very much.